Okay.
Okay. Good afternoon, everybody. Today's talk is on ADA 2022 Diabetes Guidelines. What is new? If you look at the overall revised treatment algorithm for type 2 diabetes mellitus patient, now, if you really look at it, the pharmacological treatment of hyperglycemia in adult with type 2 diabetes mellitus, first line therapy depends on comorbidities, patient-centered treatment factors like cost and access consideration, and management generally includes metformin and comprehensive lifestyle modification as the first line therapy. This is what has been there. And we know that ASCVD indicators of high risk or heart failure or CKD recommended independently of baseline A1C individualized A1C target or metformin use. So that means primarily one of the important factors is the moment a patient has ASCVD, atherosclerotic coronary artery disease, or multiple risk factors for cardiac disorders or heart failure or CKD, then irrespective of A1C level, we need to have a different approach. And that is, if your ASCVD indicators of high risk, then either you should give GLP-1 receptor agonist with proven CVD benefits, which we discussed last time, which or can be SGLT2 inhibitors with proven CVD benefit. And if your A1C is above target, for patients on this GLP-1 receptor, consider introducing SGLT2 with proven CVD benefits and vice versa. That means you can start with one and change and add another also. That is, both can be given together in a patient with high ASCVD risk. Similarly, if you have a patient of heart failure, then we know based on this DEPA heart failure trial and EMPA failure trial that you can use SGLT2 with proven benefit in this population. If you have a patient of CKD and with albuminuria, which is more than 200 milligram per gram of creatinine, or CKD without albuminuria, where the eGFR is less than 60 ml, then it is preferable to use either SGLT2 with primary evidence of reducing CKD progression or SGLT2 with evidence of reducing CKD progression in CVOTs. Or third, GLP-1 with proven benefits if SGLT2 is not tolerated or contraindicated. That means primarily all that we are trying to say over here is based on these guidelines that we use GLP-1 receptor agonist and or SGLT inhibitors for ASCVD, CKD, and only SGLT inhibitors for patients with heart failure. What you should remember is with patient with CKD, eGFR less than 60 without albuminuria, also recommendation is for the same thing. So the moment you say patient of CKD, it may be just eGFR less than 60 or albuminuria more than 200%. Now that is what has been the standard thing. We also know that we need to choose drugs with three important facts in mind. Make sure that you use a drug which causes least hypoglycemia, no weight gain or promotes weight loss, and then take into consideration the cost and access. Looking at minimum hypoglycemia, the drugs which can be used would be DPP-4 inhibitor, GLP-1 receptor agonist, SGLT2 inhibitors, or thiazolidines. However, we should know that sulfonylurea and insulin can cause significant hypoglycemia and should be used only later if your target is not achieved with the above drugs. Similarly, when you're looking at weight gain or promoting weight loss, your GLP-1 receptor agonist or SGLT2 comes high on the card. DPP-4 would be neutral weight gain-wise, and therefore they are higher on the card. Opposed to that, thiazolidine, which does not cause hypoglycemia, can cause weight gain on edema. And lastly, when cost is a barrier, then there is no question that insulin, sulfonylurea, and thiazolidine would be forming the thing. Having said so much, So that is what was the recommendation. But now a major change in this guideline is that first-line therapy normally was metformin with comprehensive. Now, as you could see, what is written in red color over there, SGLT2 and GLP-1 can be considered as an initial therapy without metformin in type 2 diabetes mellitus patients with cardiorenal comorbidities and risk of developing such complications. That means now, in a cardiovascular patient or CKD patient, you can use SGLT2 inhibitors or GLP-1 receptor agonist as first-line therapy rather than saying metformin and lifestyle being the first-line therapy.
Very true.
So that is a major change which we are looking at and indication-wise. What is another recommendation? The use of insulin and combination therapy, GLP-1 for greater efficacy and durability. This is a type A indication. If insulin is used, combination therapy with GLP-1 receptor is recommended for greater efficacy and durability of treatment effect. The first time we say that as a first-line therapy, you can use GLP-1 and or SGLT2 inhibitor. The second major change in the EPA guideline is you can use along with insulin, which can cause weight gain and hypoglycemia. GLP-1 receptor agonist, as we discussed last time, GLP-1 receptor agonist is a powerful drug for even reducing blood sugar. It reduces HbA1c by 1.5 routinely. And if your patient HbA1c is more than 9, it may even reduce by 2.5 HbA1c. So now you can use this combination, which will be synergistic. Both will be very efficacious to get down your sugar. One will weight gain, another cause weight loss, and a synergistic action will be really useful. Similarly, if a patient is on insulin, consideration for continuation of metformin therapy after patient initiated insulin is again a class A indication type 1. So primarily, there are people who say that when you have a patient who is already well controlled with insulin, probably metformin not possible. Here, answer is it is important. But again, the major benefit of synergism is weight neutral and an additional beneficial action. As we all know this has been there, the multifactorial approach to reduction in risk of diabetes complication. Now, this is extremely important that when you're treating diabetic patient, it is not only blood sugar. You will definitely expect glycemic management, but parallelly, trying to get down the blood pressure, controlling lipids, and agents with cardiovascular and kidney benefits should be added in this patient for therapy. So it is not only diabetes. In every single patient, approach to control all the risk factors gives you tremendous benefit. And therefore, adequate control of sugar, blood pressure preferably between below 130 by 80, lipid management where you will try to get LDL cholesterol depending on the risk of patient to below 70 mg%, and triglyceride below 150 mg%, and to aid drugs with cardiovascular and kidney benefits, which would be, as we already told, SGLT2 inhibitors and or GLP-1 receptor agonist. And therefore, the new algorithm based on this is that patient who is more than 18 years of old with type 2 diabetes that has more than one of the following factors like ACVD, heart failure, diabetic kidney disease, or high risk for ACVD, address concurrently, simultaneously, optimize guideline-directed medical therapy for prevention of lifestyle, blood pressure, lipid, glucose, antiplatelets, and to start SGLT2 inhibitor and GLP-1 with proven benefits depending on patient-specific factors and comorbidities. And these facts you have to discuss with the patient, and then the patient may be only on primarily anti-hyperglycemic, maybe plus minus SGLT2 to GLP-1, and reassess and consider addition of the alternative classes benefits outweighs the risk. All that we are trying to again tell you is that now SGLT2 inhibitor and GLP-1 receptor agonist has a much higher value and comes much earlier in the treatment of patient of diabetes with ACVD with heart failure, with diabetic kidney disease, or multiple risk factors.
So far, we have been using it as a last resort if others fail. The routine ones using. Now it has completely reversed. Yeah.
Absolutely reversed.
If diabetes is under control, blood sugar is under control, so we still give both.
Absolutely.
And to improve the survival.
Yeah, they could improve survival.
Also must take care of the remnant factors like triglycerides and all that. So that's
so
a very...
means every diabetic high risk should, your autoreceptor blocker and your G2
GLP-1 receptor agonist. They said that to protect your HbA1c, they should be added.
And HbA1c is so cheap also. The problem
is... Sorry, I didn't get your question, sir.
Which is cheap?
SGLT2 is very cheap nowadays.
SGLT2 is cheap, yeah.
So
what about semaglutide and other things?
That now? They are 200 rupees a day.
300 rupees, Bhaskar.
10,000 rupees a month.
And some people don't tolerate Bhaskar, unfortunately.
But they say that you have to start with a small dose and gradually up titrate. And maybe if you're successful in doing with the drugs with about 80% of people, 20% will still vomiting will tolerate it.
3 doses, 3, 7, and 14.
Yeah. So start with 3, step up to 7 period of time, and then if possible 14.
Every month you step it up to 7. 7 is the starting dose, 3 is the starting dose. And if necessary, to step it up.
Then another important thing which you have to remember is you can combine both.
Yeah.
Both.
I think
the combination in type 2 diabetes.
Asking whether we should give both. Even if
you can
control, probably you can
combine therapy with sodium glucose transport and glucagon with demonstrated cardiovascular benefit may be considered for additive reduction in the risk of adverse cardiovascular and kidney events. But both are added together is synergistic.
The SGLT2 will be better for weight reduction.
Weight reduction, GLP-1 is better, sir.
GLP-1 is better.
In terms of kgs, the average reduction of weight with SGLT2 inhibitor somewhere in the range of 3 to 5 kg, whereas with GLP-1 receptor agonist, it will be in the range of 10 to 15
kg.
That's on the baseline weight. That means the patient is 100 kg, it can go. Another important thing is they have now slightly down titrated azithromycin being preferential due to its lower cost has been removed from the recommendation. Though we still in India strongly believe that we should give for bringing down your LDL to the target level of below 70, you should, whenever the LDL is above 70 with high dose of or high intensity statin, the next drug should be azithromycin. But probably in the new guidelines, azithromycin is down. Another important thing here is diagnosis of hypertension at a single healthcare visit when BP is beyond 180 by 110 and cardiovascular disease. That means if a patient who is diabetic and comes to you with BP beyond 180 by 110, one reading is sufficient to say that he has a high cardiovascular risk and should be started on antihypertensive on the first visit itself. However, if the report is below that, then probably maybe a couple of more readings and then confirm it and start hypertension. That means diabetic tolerate hypertension works, and moment you see one reading of even 180 by 110, you should be started on antihypertensive therapy.
Both the drugs can reduce your blood pressure, Bhaskar.
Huh?
Am I right?
Both these drugs reduces blood pressure. SGLT2 inhibitors and GLP-1 receptor agonist. But the range of blood pressure reduction is systolic 5 by diastolic 3. Average.
But that's very little.
But that along with that,
they reduce weight.
I mean, you might have the patient pressure is 80 by 110. You will have to give additional antihypertensive.
Yeah, that's true.
Then eGFR threshold has been now further reduced to 25 ml per minute per 1.73 square meter area for SGLT2 to reduce chronic kidney disease progression and cardiovascular events. Now, this is what is important. Initially, for type 2 diabetes and diabetic kidney disease, use of SGLT2 in a patient with estimated GFR of 25 or more and urine albumin more than 300 is recommended to reduce chronic kidney disease progression and cardiovascular events. So the threshold is reduced. Now we can give an above. Initially it was 30 and above. To start with, it was 60 and above, then 30, and now it has gone down to 25 eGFR. Then you can start the drug. Thank you. Another important limitation which you know, okay, when you are using SGLT2 or especially GLP-1 or some other drug, people have a tendency of hyperkalemia. And in patient chronic kidney disease, or an increased risk for cardiovascular events or chronic kidney disease progression, and are unable to use an SGLT2 or a non-steroidal mineralocorticoid receptor antagonist by name finerenone is recommended to reduce chronic kidney disease progression and cardiovascular events. That means your fear of hyperkalemia can be eliminated.
Didn't get you, Bhaskar. Which is the drug that you said?
Repeat again.
When you have a patient of chronic kidney disease, you are worried of hyperkalemia.
You are not being heard properly, Bhaskar.
Oh,
That's
sorry.
the problem.
Now, can you hear me better?
Yeah.
Basically, when you are having a patient on CKD, your worry of hyperkalemia is there.
Correct.
With SGLT2 inhibitor or sometimes even with ARB, ARNI group of drugs. Yeah. Now we have a non-steroidal mineralocorticoid receptor antagonist. That means the fourth group, when you want to give MRA, finerenone is known to cause much lesser hyperkalemia and can be used in patients with CKD when you want to reduce cardiorenal complications.
But the cardiovascular benefit is good, Bhaskar.
This drug is available here?
Not yet. Not yet. But it's, when we are talking to the pharma company, it should be there in another 3 months' time.
For example, take my own example. I'm a long-standing diabetic. GFR is only 32 or 35 after my last episode of acute renal failure 6 years back.
Right.
Which drug should I take?
Hyperkalemia is not a concern, then SGLT2 inhibitor is...
No, I'm not finished my details. I am already on metformin because my creatinine level is only 1.4 or something, 1.35. But the eGFR has gone down to 35, between 35 and 32. So my problem is whether I should still stop metformin and go back to the GLP-1 or whatever, the other one.
You can add this, you can, whatever benefits of metformin. These drugs are important thing to remember. SGLT2 inhibitors would not cause hypoglycemia below 180 mg/cent. The threshold when it starts working as a hypoglycemic agent is only after blood sugar of 180 and above.
Yeah.
So there is no risk of hypoglycemia. You can continue your metformin. You can add SGLT2 inhibitor, provided potassium is not a problem.
I understand, yeah. That has not been a problem so far with me. And,
so you should add. You can continue metformin and add SGLT2 inhibitor.
Yeah. I can continue metformin till I feel it's absolutely required to change it to SGLT2 or whatever, or GLP-1.
My suggestion is continue metformin and add SGLT2 inhibitor right away.
Right away, okay.
So, and semaglutide you should add.
And that means start with 3 milligram of semaglutide or something and then decide.
But first introduce SGLT2, which is cheap and easy, one dose titration. Acceptability very high, side effects are hardly there. And after you have done that and we are comfortable, only other thing which you have to be very sure that you do not have recurrent urinary infection.
Yeah, that's true.
Because age-wise, by any chance there is enlarged prostate and UTI, then you can't use SGLT inhibitor.
Correct. That is true. Hygiene also.
Right.
Ladies, yeah.
Similarly, concept of BP variability reduction in CKD progression. Optimization of blood pressure control and reduction in blood pressure variability to reduce the risk or slow the progression of CKD is recommended. That means, besides controlling your blood pressure well, it is important to also have extremely low BP variability in order to prevent the progress of CKD. That means fluctuations in BP should be also well controlled, and you need to use drugs which has round-the-clock effect and no major fluctuation in BP variability.
And that's not easy to control also. It's not very easy.
Agreed, but the effort can be made, sir.
As Bhaskar said, the drugs
the problem.
which decrease your BP variability, like amlodipine.
Yeah, that's right.
Or even telmisartan.
I think so. Small dose of amlodipine, telmisartan.
Similarly, another concept in this new is elderly diabetic goal. Elder or older patients who are otherwise healthy with few coexisting chronic illnesses and intact cognitive function and functional status should have low glycemic control goals such as A1C less than 7 or 7.5, while those with multiple coexisting chronic illnesses or cognitive impairment or functional dependence should have less stringent glycemic control, such as A1C less than 8. Meaning thereby, even an elderly patient, if there are no comorbidities, good mental function, good functional status, the goal is 7 to 7.5. But if you have multiple disorders, coexisting diseases, cognitive impairment, functional dependency, A1C goal will be 8.
So I have a choice now between metformin and the SGLT2 or GLP-1, whatever.
Pardon your question, sir?
No, I have got a choice for. See, my metformin is completely controlling it even now with 500 milligrams 3 times
but
a
you
day.
can add SGLT. SGLT you are not going to add for control of sugar. You are going to prevent kidney damage.
That's right.
Outcome benefit.
Okay. So I'll start with say, can I use linagliptin?
You can use dapagliflozin. You can start with 5 milligram. Once you tolerate, change to 10.
Which drug?
Dapagliflozin.
Dapagliflozin.
Yeah.
Another
yes, sir. Any questions, sir?
I think you did very well, Bhaskar. That every diabetic high risk should have both this group of
drugs. Yeah, that's right.
Now, age to begin screening all people for pre-diabetes and diabetes has been now reduced to 35 years from 45 years.
Very
purely because the prevalence is high and a lot of young diabetics are detected, and therefore routine screening should start from 35 years age instead of 45 years age, regardless of risk factors like obesity or anything.
Even Bhaskar, earlier than that, even lipids also. Lipids, blood sugar, blood pressure, by the age of 20.
18.
18, yes.
Yeah. I think you have
now, this is another important thing, and that is where is the talk of all diabetologists is standardized continuous glucose monitoring metrics for clinical care and its utility. Now, as we all know that nowadays we have got a continuous glucose monitor, which is a small patch which has to be put on the body, and that gives you blood sugar for 14 days. The percentage time CGM device is active is recommended. 70% of the data from the 14 days are very useful. It gives you mean glucose level. The glucose management indicators, and which are you need to look at. One is glycemic variability, because it gives you multiple readings. You can look at a variation of glucose throughout the day. And the standard recommended is that glycemic variability should be less than 35 or 36%. Then there is a concept of what is known as TAR, time above range. That means percentage of time when your blood sugar is higher than normal. Again, there are two types. One is what is known as level 2 hyperglycemia. That means percentage of the time the readings are more than 250 mg/%. And if the percentage of time when the reading is between 180 and 250, then it is known as again TAR level 1 hyperglycemia. Then we'll come to that a little detail. TIR is time in range, percentage of reading in time when the readings are between 70 and 180. And time below range, that is hypoglycemia, percentage of reading in time which is between 55 and 70 is level 1 hypoglycemia. And between or less than 55 is level 2 hypoglycemia. Now, these are the things. Now, when you look at the CGM metrics and you have a patient, when you get a 3D charts from which you can very easily, 1 minute. Just in the lecture, so number of times, now what is important? What are the figures here? TIR, that means time in range. Percentage of time the blood sugar is in normal range should be ideally 70% or more. That means your blood sugar, if you have 10 readings, 7 times out of 10, it should be within normal range. Then you say it is, the TIR is good. So TIR value should be always above 70. TAR, which means time above range. When I say time in range has to be 70 or more, so above range should be less than 30. Simple. Because time in range and TAR put together would be primarily. So TAR, your blood sugar should not be out of the range for more than 30% of the time.
Bhaskar, the
and
device
time below range, that should be ideally 0% or as less as possible.
Yeah.
And therefore, when you're looking at a CGM curve, you would look at two important things. If the TIR is more than 70, if TAR is less than 70, and TBR is nearly 0%, that is the best control. Opposed to that, if your TAR is above 70, I mean TIR is above 70, that means normal range. But your TBR is 5 or 10, then you are worried. Because hypoglycemia is not desirable.
No.
And therefore, this CGM matrix has given tremendous benefit in finding out whether you have a variability, how often you get into hypoglycemia, how often is your blood sugar well controlled, and based on that, you can titrate the dose. There are people who have also gone and seen the variation in this with food. There are people who say, I took 2 idli and my sugar went up from 110 to 200. The next time probably motivates him not to eat that, or vice versa. And therefore, nowadays, CGM is extremely commonly used all over the world, including we see a lot of affluent class of people routinely using for management of diabetes, this CGM things, which is the patch which we applied for 14 days.
The device is
over here is that you are going to get mean glucose. Now, this is interstitial fluid glucose level and cannot be compared with your transvenous collected blood sugar. This will be about 10% or about approximately average is 9% less than the blood sugar which you have collected from the vein. So that is that is an acceptable range. In order to know whether your machine is okay or not, if for any time if your CGM values are more than 15-20%, that means there is some error somewhere.
Is the machine available here?
Yeah, this is very common, very easily available. We are using it left, right, and corners nowadays.
How much does it cost?
The overall machine, that 14 days patch would cost you around 7,000 rupees.
70,000.
7,000.
7,000 rupees.
Okay. Bhaskar, theoretically it is fine, Bhaskar. But
and nowadays, you can, even at that time, you can get a spot there is a small delay. That means the machine gives you a sugar value, and that is reflecting the sugar which was done about 10-15 minutes back. So there is a delay of 10-15 minutes. The difference between the venous glucose and this is by 9%. And you are looking at time in range, time above range, time before range, and can be wonderful used for taking care of these patients.
Bhaskar, can we use this in juvenile diabetics? Juvenile fluctuations are very high.
Right. So I'll tell you what are the clear current indication. All type 1 diabetes mellitus.
Yeah, right.
Type 2 diabetes mellitus who are not well controlled, or where you are having suddenly fluctuations of sugar from 150 and 450, or whether you are supposed to be having Somogyi effect or reverse Somogyi effect and all those things. Patients, again, this is very useful.
For juvenile diabetics during the phase of this growth spurt, when the fluctuations are very...
It is the strongest indication is juvenile diabetes, type 1 diabetes.
Absolutely.
But nowadays, the number of type 2 diabetes mellitus being very high, the percentage of people using this is much higher in type 2 than type 1, because the number primarily, absolute value-wise. And it's very commonly used, and they wanted exactly what are the normal ranges, and these are the range what I told you. Time in range 70% and above, time above range 30% or below, time below range ideally 0 or as low as possible. Glycemic variability should be less than 36%. Mean glucose should be approximately 9% less than the venous glucose. And the delay, which is there.
Is it technical, Bhaskar? In selected cases, it's fine. And selected diabetologists, it's fine. But how many cardiologists will be able to follow this?
You can, diabetologist is a cardiodiabetologist.
But is it available freely? Where is it?
Tell me, Bhaskar.
Device.
Are you following this, Bhaskar?
Pardon?
Are you following this?
I have used this machine in at least about 50 patients by now.
Oh, wonderful.
And I'll tell you,
very well.
all experienced class people.
Where is it available?
This is the machine is known as Libre, L-I-B-R-E.
L-I-P-R-E?
L-I-B, B for Bombay. Libre.
L-I-B?
R-E.
R-E, Libre.
That patch is available. It is available on Amazon, or it is available online everywhere, any medical shop, and Libre is the name. And you have two things. This is a patch, and then you have to have a machine to detect it. That is not that the company people will come and give you a graph after 14 days. If not, then otherwise that machine costs much more. One which will tell you the blood sugar on the spot in the house.
Yeah, that's like HGT.
Yeah. And this is now only one funny thing which was detected in this conference is people who start becoming too much worried about it. They start trying to get their blood sugar very tightly controlled, cut down this food, that food. And they found that the number of hypoglycemic episodes, when they start doing it more frequently, is much higher, and probably ultimately may not translate into a good long-term outcome benefits.
Yes, absolutely. Particularly in old age.
Use this, you have to tell them that they should not become too much neurotic about it. They don't have to really try and get your sugar down to 190 and 80.
That's
the standards we should remember is that the elderly patient should have somewhere between 7 and 8 only, and they should not try and achieve lower level than that.
Already you can discontinue because of the...
Start becoming too neurotic and try to get your sugar to 100 and 110 and then suddenly go into hypoglycemia.
That's right. Very nice. Thank you. Liberate.
What was new in the guideline? I think we'll stop here. This was my last slide.
Good. Well done. Theoretically, it's fine, but I don't know practically how it is. Except we have a patient like Dr. Apte who can follow it very well.
Yeah, I'm now 91. I will be soon now 90. 3 months.
I would like to see that patient doesn't become hypoglycemic, which is very, very important.
Yeah, I totally agree, sir. That is why I said the disadvantage also.
I'm therefore not yet gone into that device because already because the GFR being low, already I don't require so much of metformin also. I have reduced the dose of metformin also.
No. So these machines are only nowadays actually people who are very fanatic about weight and health and all these health check people. I mean, every day when we see patients for health checkup in Jupiter Hospital, out of 20 patients who are otherwise normal, one of them is using this machine to see whether doing idli or dosa or what happens after ice cream and what happens after
my own personal experience. After my surgery for knee replacement, I'm doing so much of exercise that I don't need anything. I'm not going to hypoglycemia very often.
Dr. Apte, there's a big secret that you have been regularly exercising, and that is why you lived beyond 90.
No, but the problem is how many Dr. Apte are there, sir?
I don't know, but there must be many.
There are hardly anyone who follow all these exercise regimes. So
I have been doing exercise for a very long time, and till the age of 79, badminton, and 75, tennis also, and sometimes both.
So I was surprised. I was with one sort of called professional groups working in IT company and had gone for a lecture about 200 and odd. Most of them normal health, non-diabetic,